Welcome to ThinkTech Hawaii Business Education Spotlight. This is Alice Li Hagan. My guest today is Art Wallace. He's the Special Assistant for Asia Pacific Affairs with the Navy Medicine West. Welcome, Art.
Thank you, Alice.
It's wonderful to have you here, and first of all, thank you for your service to our country.
Thank you.
You are a retired Army colonel, and currently you are with the Navy Medicine West. And of course, you have completed a variety of military assignments across the nation and internationally. And of course, you've received numerous awards, and I'm just really eager to find out about, well, first of all, what is Navy Medicine West? Because before preparing for my interview with you, I have unfortunately never heard of that.
Well, Navy Medicine West was a regional headquarters that Navy Medicine created in 2005. Mm-hmm. At that time, Navy Medicine was organized by a number of different headquarters throughout the country and around the world, and the communication, the flow of information was disjointed. So the Surgeon General at the time established 4 regional headquarters. Navy Medicine East, which is basically the East Coast to Europe and Africa. Navy Medicine West is the West Coast, including Nevada, Arizona, all the way to Diego Garcia. So it includes Japan, Okinawa, Guam, Singapore, in addition to Hawaii. Okay. And then we have Navy Medicine National Capital, because Washington, D.C. always needs its own product. And then the Navy Support Command, which takes care of the support and logistics of those different commands. So Navy Medicine West basically encompasses the largest geographic area, 16 time zones if you go from California to Japan, and about 26 facilities if you count the clinics and the hospitals.
So before we, I guess we were chit-chatting earlier on before the interview, and you were mentioning that this morning you woke up at 3:30 to have a telephone conference with Washington, with Guam. So how often does that happen? And since you have to cover a large geographical area, I guess your sleep pattern must be really off.
Well, you're grateful you have a job, number one. Number two, you adapt your job to the strange, well, not the strange, but the time patterns of where your senior leadership is located. And that tends to be Washington, D.C. and San Diego for me. Fortunately, the teleconference I called into this morning occurs once a month. So this time of the year, before daylight savings time, it's 3:30 Hawaii time. And nobody has any sympathy when you call in from Hawaii, because they figure I'm in Hawaii, so, right. When daylight savings time kicks in, the call is at 2:30, so that's an adjustment. Mm-hmm. But, outside of those few calls, the frequency is low until we get into some new contract and change in the way we organize our message, but it's not that frequent.
Well, then let's talk about what you do as a special assistant for the Asia Pacific region. What are the responsibilities of your position then? Well,
the position was created by Rear Admiral Hunter, who was the commander of Navy Medicine West in 2006 to 2008. When Navy Medicine West was established, she felt that there needed to be a presence in Hawaii, because Hawaii is the home of the Pacific Command, Marine Forces Pacific, the Pacific Fleet, U.S. Army Pacific, and about 50 generals and flag officers at different locations on the island are here. So she felt there needed to be a presence to be the interface between her hospitals overseas and the fact that we have so much leadership here on island that needs to be informed on changes in Navy medicine. The other major reason was Tripler is the largest referral medical center in the Western Pacific. If you need specialty care, if you have a sick child that needs neonatal intensive care, they come to Hawaii. So they needed somebody to kind of keep a pulse check on how is the support being provided to the Navy Marines, Coast Guard out in the Pacific, and I have oversight or indirect responsibility for the regional case management team, the clinical liaison team at Tripler, that takes care of family members and active duty who come here for specialty care.
So you kind of answered my question. I was going to ask you, so who are your clients? And I guess I went on your website, and you really have about, what, 600, close to 700,000?
Well, Navy Medicine West, if we count the West Coast all the way to Guam and Singapore and Diego Garcia, it's about 600, I think I looked it up, about 690,000 beneficiaries.
Oh, okay.
Hawaii alone, if you look at enrolled Army, Air Force, Navy, Marine Corps, it's got about 125,000 beneficiaries out of a total of 160,000 eligible.
Okay.
But at any given time, a lot of these folks are on ships away from Hawaii, so they may not be enrolled to Tripler or Makalapa or Kaneohe. They're being seen by the medical staff, the IDC on the ship or sub.
IDC meaning? Independent
Duty Corpsman.
Okay.
That's an advanced medical provider on the small boats and ships, because we can't afford to put a doctor on every ship.
Now, you also mentioned that even though this is Navy medicine, you have East and West, but
Correct.
at the same time, you work very closely with the Army, with Marines. So how does that work? Do you also collaborate with the Air Force as well?
The key word in today's military health reform environment is collaboration and transparency. Whatever we do, regardless of service and color of uniform, has an untoward or intended consequence down the road on the other service. So I think the collaboration is probably the highest it's ever been. We don't always agree on the way forward. We don't always want to change the way we've done things in the past, but we're being driven by a value formula, by cost reduction formula, and the need to reduce the size of the military to accommodate what sequester and the politicians are directing us towards. Now that can change depending on world current events, but I can honestly tell you that we have a round table that meets now of all the services and at PACOM, and we discuss what are we going to be doing in the next 1 to 3 years that may have a domino effect on the other service. And it's proven very valuable because for example, at one point there was discussion of moving neonatal ICU from Okinawa, but then where would we take very sick babies? Tripler obviously has a good neonatal ICU, but they have a capacity that takes care of people on the island. So that level of transparency, and I use that word with a foot stomp, because increasingly that's becoming the way we do business. We have to know what the other service is doing, so we can anticipate and flex to what meets their needs, because quite often our Navy hospitals are next door to a Navy and Air Force clinic.
Right, right.
That's true in all the overseas locations. So our patients use each other's facilities, and for all intents and purposes, when they come in to see a doctor, they don't really see the color of the uniform, they just want to make sure it's quality care.
Well, I have to say, and I was mentioning to you earlier on that a year ago, I became a TRICARE member, and I've had wonderful experience at Tripler because I was with a different provider before, but my experience there has been great. But it's certainly very unusual because I go in there, it is a military facility. But going back to what you said earlier on, there's the need to be transparent, and you're doing business in healthcare in a certain way. So it sounds like what you do has to do with a lot with communication, just trying to understand, I guess, what different services need and trying to make things work. Is that a fair summary?
It is. I think I'm dependent on how much information is shared by senior leaders of all the services. And then I basically move that message along. I may condense it so it's understandable sometimes. You know, they may give me a series of slides, and I'll just pick out 3 or 4 slides which are applicable to the Navy personnel. And then I share it with the hospital commands overseas, with the senior enlisted leader, with the executive officer. I share information going the other direction to the line community with the Marine command surgeon, the fleet surgeon, etc. So I've often joked that I should have an avatar of my face and just put it on the television, because a lot of what I do is virtual. I'm either a faceless voice on the Defense Connect Online, which is a virtual slideshow voice transmission system, but no face, because I don't have a webcam.
Maybe that's something that you should have.
That's true, but then I
perhaps.
have to comb my few hairs that I have left, so I don't know if I want that. But I think that the communication, sharing of information, and talking about what the consequences are, so people can plan proactively. If they do this, what is the implication on the sailors on my ship, my submarine? What is the cost of sending people to Hawaii? Why are they staying in Hawaii so long? You know, is somebody communicating back to that squadron commander why Petty Officer Smith is still at the Halakoa for 3 weeks? So that communication is what I call patient navigation. There needs to be more of that communication going back and forth so people know why somebody is being sent to Hawaii or onward to San Diego for some sort of specialty medical problem.
Now, since you are the special assistant to the Western or Asia Pacific region, I presume you have a counterpart with the Navy Medicine East then?
No.
Oh, okay.
And part of that is because Europe is saturated with a lot of presence because of the war, you know, OIF, OEF, the Operation Enduring Freedom and Iraqi Freedom.
Okay.
The Navy presence in Europe is very small because that is going back to World War II, the Pacific has always been the Navy, an air-sea theater, whereas Europe, under the Cold War, was a ground theater with air support. The Navy support in Europe is primarily small hospitals, very small ones, in Naples, Rota, Spain, Sigonella, and Bahrain. And so they are very dependent on larger Army hospitals like Landstuhl, where all the casualties fly through from the Middle East on the way back to the East Coast.
Okay.
So the larger Navy facilities and the larger presence is in the Pacific because of we're a blue water geographic region. We cover, 80% of the world's surface, but most of it's blue water. So that is why I think my presence is here, and the fact that we have so many time zones. And also the fact that being half Japanese, I'm familiar with the cultures that are unique, that make Asia challenging for people who are not used to Asian cultures.
I'm glad you brought up that point because I guess we're coming to a break, and after the break, I'm interested in learning about how medicine is, I guess, perhaps another way to strengthen our partnership with our alliances, and I'm hoping that you can share some of your insight with us.
Absolutely.
Wonderful. My guest is Art Wallace. He's the Special Assistant for Asia Pacific region at the Navy Medicine West. You're watching ThinkTech Hawaii Business Education Spotlight. Stay tuned. We'll be right back.
Hi, aloha. My name is Chris Leatham, and I host a show called The Economy and You. The show plays every Wednesday at noon. And on my show, I bring on guests who are interested or working in the technology space. And so I'd like you to come and watch the show and learn with me about all the sort of exciting things that we're doing in Hawaii to build and grow our economy ecosystem. So I'd like to say aloha, and I look forward to seeing you on the show. Thank you.
Welcome back. You're watching ThinkTech Hawaii Business Education Spotlight. My guest today is Art Wallace. He is the Special Assistant for Asia Pacific region at the Navy Medicine West. So Art, tell us about how medicine is a way for the U.S. military to strengthen their alliances with our partners all over the world.
Well, I can speak to the relationship we have in South Korea and Japan, Okinawa. Those alliances go back to World War II or the Korean War. And the examples I can cite are the fact that, for example, the two large Navy hospitals in Japan and at Yokohama and also in Okinawa, at the Marine Base Camp Foster, we have Japanese internship programs for Japanese physicians who are bilingual and would like eventually to do a residency or a fellowship in the United States. They compete for positions to rotate and do a one-year internship at the Navy hospital. I know the Army has an equivalent program at Yongsan in Seoul, South Korea, which goes back to the Korean War. And these programs are really to expose, they have a twofold benefit. One is to expose Japanese physicians to American medicine, because when you look at the way Japanese medical education is conducted, it's still probably, and I'm being polite here, but it's a very feudal system where you might be a resident for 5, 6, 10 years until you work your way up within the hospital staff system. In the United States, the length of the residency is based on the specialty.
Right.
So internal medicine might be 3 years, general surgery might be 5 years, neurosurgery is 7 years. But after you finish and you pass your boards, you can hang your shingle and say you're a board certified doctor. So the Japanese come into our hospitals and they serve several purposes. They teach us about the Japanese medical system and how they're educated. They tell us about some of the challenges they face within their own culture, which explains some of the issues the Americans face when they go into Japanese hospitals. It's cultural, it's definitely language related. The culture in Europe is very comfortable for the Americans because most European doctors speak English. Most Japanese doctors speak English, fluent and broken, but their staff does not. So in many places, especially Tokyo, Yokohama, we have a staff of Japanese interpreters who go with you to the Japanese hospital, because to get through the reception desk, the nurse, to the doctor, you have to speak Japanese.
Wow.
And so in those places, we have what I call two-way education. Last September in Yokohama, I attended the perinatal conference for Japanese OB doctors and neonatal doctors, which is hosted by the Navy in Yokosuka, and they invite Japanese doctors from all around that part of Japan to listen to new practices and new methods being done in the United States for part of the day, and then for another part of the day, the Japanese share with us what they're doing. So it's a collegial social event to continue nurturing the OB and the NICU relationship. In that part of of Japan, we depend on the Japanese for any complications or serious issues with babies, with trauma, because we don't have large trauma centers in those countries, so we depend on the Japanese to support us.
Well, I understand, of course, we have bases in Japan and Korea, but what about with the rest of Asia, say Thailand or the Philippines?
Absolutely.
And of course, I know that we have Mercy going out providing training. So.
Yeah. Well, the Mercy is going out, it goes out every year. Last year, there was a Japanese hospital ship that went out with American personnel. First time, Japanese took the lead. Because the Japanese are wanting to position themselves as a presence in the Far East. Because their defense budget is increasing and they want to train their maritime self-defense force in a medical role. So the training we do with the Japanese Navy and the Marines are to prepare them to play a role. And I think the Fukushima tsunami and the nuclear accident really woke them up that they needed to be more than just a Coast Guard, that they needed to have training on how do you do medical evacuation, how do you do decontamination of contaminated casualties? And the United States can offer that because we've trained on that as part of our fleet preparation and what your husband did.
Well, that was a long time ago.
Long time ago.
But now, makes me think about the RIMPAC exercise, I believe, in May last year.
Correct.
The Chinese sent also a medical ship. So what type of collaboration is there, and is this also under your jurisdiction, perhaps?
It's not under my jurisdiction, but I have attended the Asia Pacific Military Medical Conference, which is an international medical conference hosted by the U.S. Army Pacific, PACOM, different commands, in the spirit of medical partnership. And I can tell you that in the relationship we have with the People's Republic, medical is one area where there are dramatic improvements being made, because they want to know, how do you deal with evacuation? How do you deal with contingencies if there's an accident on their ships? Because their fleet is growing. You know, the Chinese are investing in a fleet. So they want lessons learned. And, you know, in the spirit of doing things under the medical rubric, we want to help them understand, let's work on this together, because there may be a catastrophic typhoon or earthquake eruption in the Far East, and we should work together in this partnership. So I see it positive in many ways. And when you asked about if you get sick, if you're traveling in Bangkok or Phnom Penh or anywhere in Asia where there's not a military base, we have a TRICARE overseas program remote contract with a company called International SOS.
Okay.
They are a former French company, AEA, and but they became International SOS in the mid-1990s, and they now provide healthcare and medical evacuation for over 300 of the Fortune 500 companies that have employees in the Far East and around the world. They are a global company. So we have partnered with them. When I worked with them in the early 2000s, it was really to take care of sailors and Marines who were traveling from San Diego to the Middle East. And if they had problems at ports of call in Singapore or Hong Kong or Manila, International SOS would be the phone number you call, collect, and you would get health care. They would have recommendations for a hospital, for a primary care doctor. And we also have about 3,000 people who live overseas in Asia in foreign countries at the embassies and research laboratories, places like that. Their families want to know, where do I go for health care?
So they service both the military and the civilians?
Absolutely. It's a separate contract with the civilians. The military contract just takes care of people in uniform who are permanently assigned for 2 or 3 years or deployed or TDY in those countries. So, and they've been a good partner with us because I went to their call center in Singapore several times, and they have trilingual nurses operating 10 phone banks. They have a 24-hour critical care doctor, and they can launch a medical evacuation Gulfstream or Learjet from any one of their 5 locations in the Far East. If you get injured in a country like Laos that doesn't have a hospital that's recommended, but they want to take you to Bangkok or Singapore or Hong Kong, where they have what they call hospitals that meet International Joint Commission accreditation standards.
Trilingual nurses, that's amazing.
At least trilingual. I mean, it was amazing. In Singapore, everybody speaks English. It's the business center of gravity, but they speak Mandarin Chinese, they speak German, Japanese. I mean, they have banks of these, what I call case manager referral nurses who are amazing to watch.
That's fascinating. I almost think that this is another topic to talk about the international aspect of military healthcare and I guess healthcare as a whole. But I'd like to bring it back to specifically military healthcare. As I said at the beginning, I really don't know much about military healthcare, and I'm just wondering, well, I know you mentioned that a lot of the services, they are trying to work together, but besides that, what is unique about military healthcare?
Well, where do I start? Actually, I'll keep it simple. I work closely with my community and civilian colleagues in nursing and in healthcare, and we often compare notes. You know, what's different between what you do and what I do. And you know, I tell them a couple of things. I said, number one, in the military, everyone's salaried. So no matter how hard you work, you're getting a salary.
Oh, okay.
And you know, if I'm a family practice doc in Kailua and I want to see 30 patients in a day, if everyone codes my appointments right, I make more money. If I see 3 patients or 30 patients in the military, or even with Kaiser, which has salaried physicians, you make the same amount of money. Now, you have business standards you have to meet, but I say salaried people that are under your control, and whereas in a private practice physician, you may have your own group practice, you answer to nobody. Doctors, I mean, hospitals come to you asking you to admit to their hospital because you generate money. So a military doctor is a salaried employee. Their big thing is readiness. I mean, the word that is constant with the military is you have to be ready at any given time to say, I won't be here next week because I'm going on a ship for 6 months. Or I'm going to in a combat support hospital in Kuwait or Baghdad for 7 months. And so being ready to deploy, I think, is an ever-present reality of military physicians. And that's not a reality for, you know, their civilian counterparts. So I think the uncertainty, especially if we go into a climate where we're engaged in conflict, the doctors, they have to augment the combat support hospitals we put on the ground. The ships and subs have their own staff, but when you start building capability to provide advanced health care for trauma, like we did at Bagram and Kandahar in Afghanistan, you bring in reserve active duty doctors and surgeons and nurses and ancillary support staff to keep that operation running 24 hours a day.
Well, I guess on the civilian side, we don't encounter that.
No, you do have inner city urban hospitals that are like combat zones, and we actually send our doctors. When the wars first started, you know, after a war has been going on, you become exposed to trauma. But when you want to train young surgeons for trauma, we looked at Jackson Memorial in Miami, Ben Taub in Houston, Cook County in Chicago, USC, LA County in Los Angeles, because they have gunshot wound trauma. So you want to prepare your staff for what you encounter when you get off the plane. And I think trauma training is a constant, in peacetime, it's a constant challenge, because mannequins can only teach you so much.
Very true.
You know, a slideshow can only teach you so much. But when you deal with live human beings dealing with gunshots, the military, in my opinion, starting with Vietnam, when I was at Baltimore Shock Trauma, the use of helicopters for taking casualties straight to the emergency room or the shock trauma center, that doctrine came out of Vietnam, because we started using helicopters to fly casualties from where they were hit back to a place that could take care of them. Instead of in World War II, where you hoped you had a medic with sulfur powder nearby and a jeep that could take you to the tent with a doctor.
We've come a long way.
It's the survival rate on some of the injuries we've had in the past 10 years of war are amazing recovery stories that you see on television and on the media. And I think that, you know, that's the greatest attribute, reflection I can have on how military medicine has made a difference. In the most horrific times, we make advances in clinical practice. However, you know, you use it for what happens in our peacetime environment, like when the Congressman Giffords got shot in the head. The Navy trauma surgeon had seen head trauma in the war, so he was the right person to do neurosurgery on the Congress lady.
This is a great lead in to talk about collaboration with civilian hospitals and healthcare facilities, because you were mentioning that some of the younger physicians, you will train them in, I guess, inner city hospitals so that they become more familiar with how to deal with, I guess, traumas. So talk to us about what other collaboration you may have between the military healthcare and the civilian healthcare.
Well, for example, in Hawaii, University of Hawaii Medical School and the nursing schools around the island, from Kapiolani Community College to Chaminade to HPU. When I was chief nurse at Tripler, we had anywhere from 300 to 400 nursing students, LPNs, et cetera, rotating through the hospital, getting their clinical proficiency training. And Queens, the other large hospitals on the island, do the same thing. But nursing units have a capacity on how many students they will accommodate, because there has to be a faculty person with them, and there has to be a preceptor who watches the students. So Tripler's relationship with the local schools of nursing, with the medical school, we have a Hawaiian psychology program to teach Native Hawaiian psychology. Dr. Folan runs that program. The two of our internists who developed telemedicine went to John Burns School of Medicine, to teach telemedicine to the doctors who had to treat patients on neighbor islands. The Veterans Administration has used their expertise to train, to track mental health patients virtually on the neighbor islands, American Samoa, Saipan, and Guam. And I would say the VA is the largest user today of telemental health. So a lot of what we do, especially in telemedicine, because increasingly I would predict that as we get medical apps on our smartphones, and we all have a webcam so we can watch our grandchildren, you're going to see medicine coming into your home for the routine prevention. How are you doing? Have you had any issues since your operation? And a lot of that is coming from the military and being shared with the civilian sector, because I think telemedicine is the next frontier.
And I presume telemedicine will also help reduce the cost of healthcare as well.
It will. It will keep people taking their medicine. It will remind them, have you checked your sugar today? Because population health is a big component of what we do today. And population health assumes that patients are going to buy into their self-care. Especially those populations that may not have had health insurance in the past. Now that they have it, it's not all physician-driven care. It's having the nurse or the LPN or somebody monitor your care and ask you, how are you doing? Are you eating the right foods? And sometimes it's just having an authority figure or somebody you respect or somebody you like telling you, this is what you need to do to lose 5 pounds or to stop smoking. This is a gift to your children, you know, uncle, auntie, grandma, whatever. And so I think that level of communication is critical. And the military and civilian partnerships, the Pacific Partnership, which I alluded to, is the the Mercy going out, and it'll go out this summer with about 600 Navy personnel and nursing students from UH, nurse practitioners, and a kind of a collection of different services and non-governmental organizations like Project Hope and others, and they'll go to remote places in the Pacific and do healthcare in the spirit of showing that we're in a Navy ship, but we also take care of people in peacetime too.
That's great. Now, we're coming up on our second break, so I'd like to talk to you later on after the break about some of the initiatives that the military healthcare has launched.
Okay.
So we'll continue with our discussion. My guest is Art Wallace. He's a Special Assistant for Asia Pacific Region, Navy Medicine West. We'll be right back.
Hi, I'm your host on ThinkTech Asia, Bill Sharp. I look forward to you joining us each Monday between 4 and 5 o'clock when we film right here in our studio in downtown Honolulu. The show, ThinkTech Asia, focuses on contemporary events in Asia, and by Asia we mean anything from Hawaii, south to Australia and New Zealand, west to Pakistan, and as far north as the Russian Far East. Clearly, this is one of the most economically dynamic centers of the world, and we bring you up to date on what's going on in a whole host of countries in this very vital region. We look forward to seeing you. Aloha.
Welcome back to ThinkTech Hawaii. This is Alice Li Hagan. My guest is Art Wallace, and he has been talking about his responsibilities as the Special Assistant for Asia Pacific Region Navy Medicine West, and how the military healthcare here has been building our alliances with our partners around the world. So, Art, before the break and all along, we've been talking about the different projects and how collaboration military has with the civilian healthcare community. I guess you face similar challenges cost-wise, how to provide quality care. Now, I know that there is an initiative called the Enhanced, and I have to look at my notes, multi-service markets. Can you tell us something about that?
Absolutely. It's interesting that the new Secretary of Defense, Ashton Carter, in 2013 signed a memorandum that came from the Pentagon, basically directing all the military healthcare services that we need to start reforming how we do healthcare. And a couple of major things came out of this. One was the Surgeon Generals of all the services, Army, Navy, Air Force, were going to fall under the Defense Health Agency. TRICARE management activity was disestablished, disbanded, and what's being built in its place, it's an ongoing process, is the Defense Health Agency. Now, some people call it purple healthcare, which means one color uniform for everybody. Now, that's not going to happen anytime soon, but healthcare really is purple. When you go in, you see a doctor, you see a nurse. You don't say, what color is your uniform? You know, some people might, but realistically, the word purple indicates that it's tri-service, and that's the way we do things. So Ashton Carter directed 4 mandates to rein in the cost of military health care. Dr. Chu, Kenneth Chu, in 2005, predicted that the military health care budget would escalate from $30 billion to $52 billion by 2011, and it would start taking money away from military modernization and other important military programs because healthcare was skyrocketing. And in actual fact, he was very accurate. The cost of military health care, the annual budget is around $55, $58 billion, which takes...
and what is that a percentage of the entire defense budget then?
The defense budget is about $500 to $600 billion. So, you know, we're talking 10%, which is a huge amount because it was 4 or 5% 20 years ago.
Oh, wow.
So what's happening is we have a growing number of beneficiaries who aren't, they're living longer because they're living healthy. Plus, medical science is advanced, so if I give you a certain pill or replace a certain joint, you'll live longer. So it's a kind of a self-perpetuating cost cycle that as we become more efficient in managing longevity, we also increase the cost to the system.
Right.
And so they always say that the major cost of healthcare is the first 6 months of life and the last 10 years of life, because that's when you're replacing everything that's replaceable in your body. And so the other thing is that 2/3 of our healthcare costs today is because in our direct care system, which takes care of patients, is off base. It's downtown in Queens or Straub, and I'm talking locally. And in Washington, D.C., it's just as high. San Antonio is just as high. So Dr. Carter said, let's come up with 6 enhanced multi-service markets which own 30% of our healthcare costs, are the reason why we have these costs, and let's start optimizing their hospitals. In other words, bringing the care back into the hospital instead of just referring them downtown to justify your payroll and your staffing. So Hawaii was one market, Puget Sound, Seattle, Tacoma was a market, San Antonio was a market, a large market, Washington, D.C., Tidewater, which is Norfolk, Virginia, another big Navy base. And then Colorado Springs, which is a small Navy, Air Force facility with an Army hospital nearby. So they were given the mandate to come up with a 5-year business plan that would generate initiatives to recapture care and do things more efficiently under a tri-service initiative. And so some of the initiatives from this area are, it used to be if you were Navy, you had to go to Makalapa, even if you lived in Neva Beach. And you may want to go to Noelani or Schofield Barracks. So under one of the business processes that's unfolding is you can enroll wherever you want to, depending on where you live. And that's customer friendly.
Right, right.
Instead of you having to go to Mecca, you can actually pick the closest place you want to go to, facility. Open enrollment. You can say which physician you would like to have if you're dissatisfied with your primary care manager. We're looking at emergency room recapture. And this is true in the civilian and military side, but 40 to 50% of emergency room visits don't need to be in emergency room.
Right,
They can be
that's
seen
right.
in primary care. So Tripler, along with the Air Force and Navy, are developing a low acuity pathway, urgent care, fast track. The terms are kind of synonymous depending on where you are. To see people with runny noses that you just picked, a child you picked up from the babysitter, doesn't need the emergency room, but the clinic is closed. So they're trying to appoint you to a next available appointment tomorrow, do things efficiently, and save money on emergency room costs, because emergency rooms are expensive. The use of Relay Health and TRICARE Online, so you can make an appointment online instead of waiting for somebody to pick up the phone.
Right.
And speak to your doctor or his nursing team using Relay Health.
Yes, and I've actually tried that, and it worked.
It worked.
Now, so currently there are only 6 of these markets. So is there a plan? So is this almost like a pilot project?
Absolutely.
And if it goes well,
It
then
will expand to the rest of the military healthcare system. I think the Defense Health Agency is only in its 2nd year of formation. What they call shared groups, or all the services are starting to work together to come up with solutions in each of the major topic areas: the healthcare plan, logistics, medical education and training, and this is causing, as expected, a lot of debate and discussion as to who does what and who has the driver in this particular initiative. So it's what I call storming and norming. There's a lot of things going on in these groups.
Right.
I think a lot of people are realizing that this is the end state we need to move toward. However, you have very intelligent people stating their opinions, and it will take time. But what's driving this is Congress. Congress is saying we have to do things more efficiently, maintain the quality, maintain patient safety, and you've got to stop calling vanilla ice cream a different flavor depending on which base you go on to. It's vanilla ice cream.
Well, Art, you've been in healthcare for a long time, for 30 years. More than that? More than
38 years.
But you're still so committed, so passionate. Now, earlier on, you mentioned your background. You are half Japanese.
My mother was from Chiba, which is now Narita Airport.
Ah, okay. And I remember reading your bio. You said that you are dependent of the Cold War. You've been educated in Morocco, Germany, England.
Turkey.
That's fascinating. I think I can almost do another show or conversation just about you. But with all this background and your experience in healthcare, can you tell us some memorable experiences you've had?
Well, I think as far as work experience, the
Mm-hmm.
most memorable was working at the White House with President Bush Sr. and
Mm-hmm.
President Clinton.
Hmm.
One of the more humorous moments was President Clinton, when he was a Rhodes Scholar at Oxford, was our guest speaker at our commencement in high school.
Okay.
In 1970, Wembley Town Hall, London, England. He was our third pick because the first two picks couldn't come.
Little did we know, right?
Well, we didn't know he was going to be
Right,
president,
that's
but-
right.
So he came and spoke, and I was not the valedictorian. I was the senior speaker, which meant the person who picked the short straw to speak to the seniors on something other than what the valedictorian was going to speak about.
Okay.
And so when I was at the White House,
And you were the White House.
I was one of the
nurse
nurses at the White House.
Mhm.
Actually, the first male nurse at the White House. So I broke the sex
Really?
barrier.
Wow.
I don't know if that's good or bad. But so anyway, I brought out my commencement brochure and I said, Mr. President, do you remember speaking at the high school commencement at London Central High School? I don't remember. I speak to a lot of groups. I said,
Right.
you're right, Mr. President. Just wanted to ask. So,
Mhm.
but the other memorable moment was defeating President Bush and his son Marvin in the White House horseshoe tournament. That was a hilarious moment because President Bush was trying to use.
Horseshoe tournament.
It's a horseshoe tournament every year because the president loves horseshoes. Each agency, the groundskeepers, the gardeners, the cooks, Air Force One, the communications, the medical, we'd all submit horseshoe teams. So I happened to have a senior chief in the Navy who was a ringer, as they say. She could hit the horseshoe pole real well. And we made it to the championship. And the hilarious thing was President Bush brought out the Secret Service in sunglasses to stand around us to try and intimidate us in the horseshoe tournament. We already knew most of these agents, so it was a tongue-in-cheek exchange of jokes to try and distract us from getting points in the
I
horseshoe
see.
pit. And I remember that because it was just, we won and we got our picture with the president who looked sad that he lost the horseshoe tournament. But I think the other thing is, just being connected with my family in Japan and England. I think as a child of immigrants, my mother's house was bombed World War II. My father delivered the newspaper in London during World War II. And so I felt very obligated to the legacy and the tradition of my families back in those countries. My one regret is after World War II, my mother didn't want to teach. She decided not to teach us Japanese because of the sentiment in the world at the time.
I see.
In the 1950s. So I think my one regret in life is that I never became fluent in Japanese so I could have, a conversation with my cousins and second cousins. But we make do with pidgin. They speak pidgin English, I speak pidgin Japanese.
Okay.
So we have a good time.
So, and you still have a lot of family in
Cousins.
cousins in Japan.
They cosmetologists, sushi chefs, and ancient wood carpenters.
That's amazing. Thank you so much, Art. I think we can continue with our conversation, but it has to be offline. So,
Absolutely. Okay.
thank you so much for being here.
Thank
I've
you very
enjoyed
much.
my conversation. All the best with your position, and
Okay.
I hope we'll get an update again sometime in the future.
Thank you, Alice.
Thank you, Art. My guest is Art Wallace. He's the Special Assistant for Pacific Asia region with the Navy Medicine West. This is Alice Li Hagan, and you've been watching ThinkTech Hawaii Business Education Spotlight. Do join us next week. Aloha.